Hi, everyone. I want to welcome those of you in person back for day two and all of you online. Thanks for logging in again. Um, my name is Eli Klemperer. I'm an assistant professor of psychiatry here at the University of Vermont and the associate director of the Vermont Center on Behavior and Health. Really looking forward to day two of our 12th annual VCBH conference. I thought yesterday's talks were fantastic and really especially enjoyed the conversation after each seminar. It sort of leads to some thought-provoking ideas, which I appreciate. Do want to note one piece of housekeeping. There was a misprint in the hard copy programs today. So the wrong talks were listed for session 5. Just want to note Dana Carroll will be speaking at 1:45. Her talk is entitled Very Low Nicotine Cigarettes in a Marketplace with Alternative Nicotine Products. And I'll be giving the final talk of the day. My talk is titled Frequency of E-Cigarette Use as a Mediator of Effects in 3 RCTs of Reduced Nicotine Cigarettes. So those are the last 2 talks of the day. We hope you all stick around in person and online. Before I get started today, I just want to give a big thank you to Chris Pung and Susan Enos. Susan isn't online. Chris is here. Phenomenal team that makes this conference possible every year. So thank you very much. So I want to pause for a sec and acknowledge John Hughes, who was truly an amazing man in the field. He was a professor here at UVM for over 35 years, and his work, he passed in March of this year. His professional legacy will be honored in full at SRNT this year, so I won't get into the details of which many of you in this room and online are aware of, but just some personal remarks. John was truly an incredible man. He was my mentor. And he shaped the way that I think about the world and I think about science. And you know, the one quality of John that sticks with me and that I think others would acknowledge as well was his integrity in science and the way he conducted himself. And I think you sort of see that in the people's lives he touched. But you know, his professional legacy, his academic legacy lives on. And just like Steve mentioned with Warren yesterday, I think you'll see that in many of the talks that you hear today. So today's topic is focused on tobacco use in the intersections of chronic health conditions, rurality, and sex. I think this is such a timely topic because the focus on vulnerable populations and intersectionality is something that as researchers or clinicians or policymakers, we're all addressing when we address tobacco use, whether we acknowledge it and focus on it like we'll do today or not. The changing demographics of smoking in the US has been represented in a number of ways. I really like this figure you see here from Cassandra Stanton and colleagues in a 2016 paper in Preventive Medicine, which I just think so clearly illustrates this widening disparity in those with co-occurring chronic health conditions versus in the general population. You see this in rurality, you see this in intersectionality with sex, which we'll hear about later today. But it highlights the fact that if we're studying tobacco use, increasingly we are studying people with co-occurring chronic health conditions and socioeconomic disparities, rurality, sex differences. And those are all things you'll hear about today. In addition, with the rise of non-combusted nicotine products, which have the potential for tremendous harm reduction, that's disproportionately or appears to be disproportionately affecting people who smoke cigarettes, use tobacco, something else that will be highlighted in a number of talks today. So I'm very excited for another wonderful lineup. I think we'll have more stimulating conversation and looking forward to getting started. So with that, I'll turn it over to Steve Higgins to introduce our first speaker. Thank you.
Thank you, Eli. Yeah, come on up, Chris. So I have the pleasure of kicking us off by introducing Janet Audrain-McGovern. And even though Janet and I don't know each other real well personally, I've been an admirer of her work for years. So Janet's a professor and director of the addiction sections in the Department of Psychiatry and a member of the Abramson Cancer Center at the University of Pennsylvania. She has extensive tobacco use research experience, including tobacco regulatory science. Janet's research has varied in study design, longitudinal cohort randomized clinical trials, human laboratory studies, tobacco product, combustible cigarettes, e-cigarettes, cigars, IQOS, nicotine pouches. See why I admire her work? She does a lot of it. And then she studied different populations, adolescents, young adults, adults, depression-prone, exclusive e-cigarette users, et cetera. As an example, she conducted longitudinal cohort studies of adolescent tobacco product uptake, and that's when I first contacted her work. Her work is behavioral economic informed, human laboratory studies of nicotine and flavoring effects on use behavior, tobacco product switching studies, randomized smoking cessation clinical trials among both youth and adults. So over the past decade, much of her research findings have had regulatory implications. And then she does a lot of service. She's been the director of postdoctoral training for 3 NIH P50 tobacco research centers, co-director of 2 FDA-funded tobacco centers, a regulatory science career enhancement course. And she recently completed 4 years of service to the NIH study section, interventions to prevent and treat addiction. So she is busy and does a lot of good work. So let's give her a warm welcome.
Thank you for that wonderful introduction. And I also want to thank the organizers of the meeting for inviting me to be here. As a short person, let me know if the microphone needs to be adjusted. So IQOS, what is IQOS? Well, IQOS is a heated tobacco product. It's a rechargeable electronic device that heats rather than combusts pressed leaf tobacco to produce a nicotine-containing aerosol for inhalation. It's the only heated tobacco product authorized for sale in the US, and it was authorized for sale by the FDA in 2019. So because IQOS heats rather than combusts tobacco, there's less toxicant exposure than combustible cigarette smoking, offering a potentially less harmful means of nicotine delivery for those who would not otherwise quit smoking. So the FDA designated IQOS as a reduced exposure product based on data. So its value as a harm reduction tool, however, appears to rest on smokers fully switching from their combustible cigarettes to IQOS. So survey studies have documented that most HTP users, because there's several types, there's several different brands of HTPs across the globe, that most users continue to smoke cigarettes. But the clinical evidence for the substitutability of IQOS for combustible cigarettes is sparse. So the questions that I'm going to seek to answer through this talk are, can adults who smoke fully switch to IQOS? Which factors drive switching from combustible cigarettes to IQOS? And do these effects differ for men versus women? So initial research on the substitutability of IQOS for combustible cigarettes comes from Italy. So in this particular study, 39% of the participants were able to transition from combustible cigarettes to IQOS, measured by a CO less than 10 parts per million after 12 weeks of IQOS provision and behavioral smoking cessation counseling. We conducted the only study in the US with 33 adult smokers, and we showed that IQOS resulted in a 75% reduction in cigarettes per day, with approximately 20% of participants completely switching after 14 days, and they did not receive counseling. So these findings highlighted the potential impact of IQOS on combustible cigarette smoking, and also suggested that in order for people to shift away from their cigarettes to IQOS, IQOS must have features, aspects that make it substitutable. So what would make one product, an alternative nicotine delivery product, substitutable for nicotine? Well, it's probably going to have some negative reinforcing properties, meaning that it takes away craving and withdrawal. It's probably definitely going to need to have some positive reinforcing properties, providing reward and reinforcement. What the literature showed to date was that IQOS use does reduce abstinence-associated craving and withdrawal. Users find IQOS moderately rewarding, not as rewarding as their own cigarettes, however. Abstinent smokers prefer IQOS relative to combustible cigarettes as the reinforcement schedule for earning puffs becomes increasingly lean. That's a behavioral economic paradigm. Our own pilot research mapped on what we measured in the lab onto subsequent behavior and found that the reinforcing value of IQOS relative to cigarettes predicted fully switching. Whether or not these effects differ for men versus women is not known. And why is this important? Well, we know that there are definitely sex differences in response to the 3 FDA-approved pharmacotherapies for smoking cessation. Women don't do as well with nicotine replacement. Women don't do as well with bupropion, and varenicline closes that gap, evens it out, women responding almost as good as men. What the research shows, and Ken Perkins established some of these relationships back in the 90s and solidified them in the early 2000s, is that women show a greater response to the non-pharmacological effects of cigarette smoking compared to men. So they really tap into that overlearned behavior of putting something towards your mouth, to inhaling, to feeling those sensory aspects of smoking, and it's less tied to nicotine. So to think about, women have fewer options, fewer helpful options for pharmacotherapy. For those who do not want to quit smoking, or they failed with traditional pharmacotherapy, then alternative nicotine delivery, non-combustible alternative nicotine delivery options may help close that gender gap in cessation. Now, one industry-sponsored study showed that sex was not a predictor of IQOS adoption. We wanted to evaluate whether or not IQOS can close the gap for women in cessation because they have fewer opportunities, fewer efficacious and effective opportunities to quit smoking. So our objectives were to evaluate whether IQOS can fully substitute for cigarette smoking, or whether dual use is closer to the norm. We examined which IQOS-associated effects measured in the lab predicted cigarette smoking in the natural environment. So our outcomes included reduction in cigarettes per day, as well as the substitution rate. So the rate at which participants substituted IQOS for their combustible cigarettes. The drivers of substitution or switching that we measured in the study included craving and withdrawal relief, subjective reward of IQOS, and the reinforcing value of IQOS relative to cigarette smoking. And we also, in subsequent work, looked at differences between male and female smokers. Our protocol was a 21-day protocol. For those who were eligible, they collected their spent cigarette filters for 5 days, so we could get a really good baseline rate of cigarettes per day. They came into the lab on day 6, and that's where we measured subjective reward. Day 7, they came into the lab again, and we measured the relative reinforcing value. Day 8, they were instructed to switch to IQOS. And then every 3 days after that, they came into the lab. We collected their spent heat sticks. And if they did smoke cigarettes, we collected their spent cigarette filters. They had a 14-day switch phase, which ended at the end of the day on day 21. On each of the visits, we also measured CO. So day 6, they arrived after overnight abstinence, approximately 10 hours. We measured their CO, craving, and withdrawal. And then we exposed them to one of 2 IQOS flavors in a counterbalanced order, either tobacco or menthol. And after each exposure, separated by 45 minutes, we measured reward, craving, and withdrawal. So subjective reward was measured by the CES subscale. So it's a hedonic value. Was it satisfying? Did it taste good? Day 7, we measured the relative reinforcing value of IQOS. And it's at this slide, I just want to pause for a moment and recognize the impact that Warren Bickel had on my research and the types of constructs that I think about on a daily basis. So without his influence and his work, I probably wouldn't be standing here today talking to you about concepts of relative reinforcing value, substitutability, breakpoint. So I just wanted to acknowledge that. So on day 7, folks came into the lab after overnight abstinence. We provided instructions for a behavioral economic task that measured the relative reinforcing value. It's a willingness to work task. Participants had 2 screens. One screen, they could press icons of images of IQOS. And that was on a fixed ratio 25. So they had to click those images 25 times in order to earn a puff of an IQOS. The second screen was a cigarette puff earning screen where they had the opportunity to earn puffs of cigarettes. That was on a progressive ratio 25 schedule where each of 10 trials, the amount of work that they had to conduct to earn a puff increased by 25. So if all 10 trials, if they worked for cigarettes, they would have clicked that mouse on an image 1,375 times. At the end of the task, they took their earned puffs, whether it was all cigarettes, all IQOS, or a combination thereof, and then they waited in the lab for an hour. And the reason why we did that is we wanted them to really work for the reinforcer that they wanted rather than the reinforcer that would get them out of the lab sooner. They didn't know that one was on a different schedule than the other, but just in case they figured it out, we wanted to make sure they worked for what they wanted. Oh, the outcome of that task is a breakpoint, which is the highest trial completed out of 10 to earn cigarette puffs. Folks needed to be 21 to 65 to participate, to smoke 5 cigarettes a day for at least a year, no immediate plans to quit, but had some interest to quit in the next 6 months, and they had to have a CO greater than 10 parts per million. The exclusion criteria were pretty standard. They were excluded if they used other nicotine products regularly, if they used specific medications like opiates or stimulants, and the reason why we excluded on that is we wouldn't be able to discern whether that was prescription or recreational, regular substance use except cannabis, unstable medical or psychiatric conditions in pregnancy and lactation. So in this sample, we had 90 participants. They smoked about 13 cigarettes per day, 51 years old, 59% were African-American, 36% were white, 58% of the sample was male, moderately nicotine dependent, found IQOS to be moderately rewarding. Overall, the break point was on average 7.69, so they really worked for cigarette puffs. We also dichotomized that at 5, which is kind of like the indifference point. So we had 19% with a lower break point and 81% with a higher break point. Right. Now, picture is worth 1,000 words. So 13.4 cigarettes at baseline. On the switch day, which was day 8, they dropped to 5.4 cigarettes per day. And by the end of the switch period, they were at, on average, 4.4 cigarettes per day. So they were smoking at about 29% of their baseline smoking rate at the end of the 2 weeks. 7.7 heat sticks per day on the switch day, increasing to 8.9 at the end of the switch period. We looked at CO changes across time, and for those who did fully quit, their CO was less than 5. During the last 7 days of the switch period. For those who did not switch completely, their CO moved from about a little over 15 to about 12. Now, we looked at what factors predicted the reduction in cigarette smoking. And the only factor that was significant was reinforcing value. So the main effect of reinforcing value was not significant, but we did see that the impact of a lower reinforcing value increased across time, such that at the end of the switch period, those who had a lower RRV were smoking about 23% fewer cigarettes than those who had a higher RRV. We also looked at the substitution rate, meaning what was the percentage of heat sticks that one substituted for their cigarettes per day at baseline. And we found 2 variables that predicted the substitution rate. The average substitution rate was 83%, but greater reward increased the substitution rate by about 14%, and greater nicotine dependence decreased the substitution rate by about 14%. So IQOS use was associated with about a 70% reduction in smoking. Heat stick substitution was high, 83%, and about 20% fully switched. So that means the majority were still smoking cigarettes and using IQOS at the end of the 14-day period. Those who experienced IQOS as rewarding, and those who had a lower or a higher reinforcing value of IQOS relative to cigarettes were more likely to transition away completely from their combustible cigarettes. So the implications of that are non-combustible nicotine delivery alternatives must be rewarding and reinforcing to replace combustible cigarettes, as the removal of craving and withdrawal is insufficient. And it's important to note that what we know as common measures of abuse liability are the same measures that are important in substitutability. So in order for one to substitute an alternative nicotine delivery product for their cigarettes, it has to be rewarding and reinforcing. It has to be able to compete. So efficient and sufficient nicotine delivery for IQOS is important for substitution, especially among those who have greater nicotine dependence. So because IQOS 3.0 version does not deliver as much nicotine as an average cigarette, those who are more dependent are not able to substitute IQOS as much as those who are less dependent. So they need their cigarettes for that, or they end up using far more IQOS to close that nicotine gap. Subsequent versions of IQOS are anticipated to have more efficient nicotine delivery and more nicotine delivery. So it's going to be important to monitor that with subsequent generations. Those who have failed to quit smoking with traditional smoking cessation medications are using alternative nicotine delivery products such as e-cigarettes as cessation tools at increasing rates. So aiding the transition to a less harmful product and matching adults to a product that can compete with their cigarettes may translate to less dual use and a greater transition away from combustible cigarettes. And Eli and I just submitted a grant. Hopefully we'll be able to increase our knowledge in that area. So do these effects differ for men versus women? In a slightly larger sample, we were able to look at some of these sex differences. And what we found was that in general, men and women do not differ on any of the variables, such as relative reinforcing value, subjective reward, abstinence relief, meaning craving relief and withdrawal relief. The only difference that we found was baseline craving. So does IQOS use impact cigarette smoking differently for women versus men? In a non-adjusted model, what we found was the answer to that is no. When we examined a model where we adjusted for the effects of baseline craving, we found that men and women across time have a reduction in their cigarettes per day. Their slopes are significant, but they're not significantly different from each other. So they're both men and women are decreasing their cigarettes per day. We bootstrap for standard errors, and once again, those slopes are not significantly different. So do women replace more cigarettes with IQOS than men? When we looked in an unadjusted model, we see that women are substituting fewer heat sticks per day than men, but it doesn't hold up with when we bootstrap the standard errors. In a model where we adjusted for some of those baseline craving variables, we find that both men and women are increasing their use of heat sticks across time, men a little more than women. But we found, and that is, those slopes were significantly different, but not when we bootstrap the standard errors. So when we looked at just simply daily count, we can see here that a picture is worth 1,000 words and at least 500 tables. That's the exchange rate. We can see what's happening with men and women. With the blue and the red line, we can see that's heat sticks across time. Men are using a little bit more than women with cigarettes per day. We see that women they have fewer cigarettes per day than men, but they started off that way as well. When we looked at our outcome variables, which is the consumption relative to baseline, we can see that they're very close. We can still see that men are using more heat sticks than women, but it's not significantly different, and there's a lot of variability there. That's also why we bootstrap the standard errors. When we look at the picture of what the regressions were showing us, we can see that they're very close in reduction in cigarettes per day, as well as heat stick use. And you may be thinking, well, is this a byproduct of your sample size? Did you not have enough, participants to really detect this difference? So this difference was small. The effect was 0.18. It suggests that we would need about 1,000 participants to find, a significant relationship 80% of the time. But the key here is the difference is rather small. So even if we did enroll 1,000 participants, would that difference be meaningful? And I don't think it is. I don't think it would be. So men and women respond similarly to IQOS: comparable craving and withdrawal relief, subjective reward, and relative reinforcement. So IQOS uptake and the effects of IQOS use on cigarettes per day do not differ by sex. Behavioral and sensory effects of IQOS use, and we of course can't separate that from nicotine, appear to help women cease cigarette use as much as men. Among women who have failed to quit smoking with traditional smoking cessation medication, the question before us is, can alternative nicotine delivery products help close that sex gap in cessation? And as Nancy Rigotti mentioned yesterday, we haven't seen any new medication in almost 2 decades. So looking for alternatives to help folks stop using combustible products is key. So 80% of people who smoke significantly reduced their smoking rate, while 20% were able to fully switch to IQOS across 2 weeks. Positive reinforcing effects of IQOS fostered IQOS use and the transition away from combustible cigarettes among those who completely switched. Such effects appear to be comparable for men and women, offering a harm reduction option to women as they have fewer efficacious medication options than men. Adults who are more nicotine dependent substitute IQOS for cigarettes at a lower rate. So what do we need to do in the future? Well, it would be good to determine if IQOS use results in smoking cessation among those seeking to quit by switching to IQOS, and if harm exposure is reduced when switching is not complete. Evaluate IQOS for longer duration. I think, when we proposed this study in 2021, if I could go back to Janet circa 2021, I would have made certainly a longer switch period. Also examining whether sex differences emerge after a 2-week switch period would be key, because it seems that with non-combustible alternative nicotine delivery products, folks take longer to take a little longer to maybe become abstinent. So eliminate all cigarettes takes place across time versus what we see typically in cessation trials, where more people quit and then they relapse across time. Compare sex differences between alternative nicotine delivery products to advance the science of harm reduction products, I think, is important to optimize this transition away from combustible cigarettes for both women and men. I didn't acknowledge ahead of time that I don't have any disclosures. This grant was funded by NCI and FDA, and I just wanted to acknowledge my collaborators on this work. Thank you.
For that wonderful talk, Janet. And so now we will hear from Karen Kaza. And Karen is an assistant professor of oncology at Roswell Park Comprehensive Cancer Center. For more than a decade, her work has leveraged large-scale population-based data sets to investigate tobacco product use behaviors occurring in the real world to inform tobacco regulatory decisions for the betterment of public health. Karen led seminal work from the population from PATH study, including establishing the study's foundational tobacco use estimates published in New England Journal of Medicine. She has worked extensively with the International Tobacco Control Policy Evaluation Project, where her work demonstrated effectiveness of smoking cessation medications when used in the general population, consistent with clinical trial indicated medication efficacy. Karen received a PhD and Certificate of Advanced Study in Applied Statistical Analysis from the State University of New York at Buffalo. Welcome, Karen.
Well, good morning, everyone. It's great to be here. I want to thank the conference organizers for inviting me. This is my first time at this conference, and it's been just absolutely lovely. So also a little shout out to Chris over there for all the behind the scenes work to pull it together. All right, so let's see here. And where are we with here? Okay, I think. Okay, oopsies. So I'm from Roswell Park. So first I'd like to acknowledge the Haudenosaunee Confederacy and the Onondaga, who are the original caretakers of the land on which Roswell Park stands. At Roswell, we aim to foster an environment that values cooperation, respect, and lifelong learning while incorporating the wisdom and contributions of Indigenous peoples. For funding and disclosures, I will be talking about the PATH study today, which is a massive data collection effort funded by NIDA and FDA under a contract to Westat. All of the unpublished data that I'll be sharing with you today were generated through a data use agreement between Roswell Park and NADAP. The content of this presentation is solely the responsibility of me, and I have no conflicts of interest to disclose. So to get started, I wanted to talk a little bit about the literature thus far on e-cigarette use and cigarette smoking cessation. In 2018, the National Academies of Sciences, Engineering, and Medicine came out with their e-cigarette report, in which they concluded that there was moderate evidence that frequent use of e-cigarettes among people who smoke cigarettes is associated with an increased likelihood of cigarette cessation. Then in 2021, Wang and colleagues came out with a meta-analysis where they found that daily e-cigarette use was associated with greater cigarette quitting compared to non-daily e-cigarette use, or compared to no e-cigarette use, pardon me. And then the Cochrane Review of Clinical Trials currently concludes with high certainty that e-cigarettes with nicotine increase cigarette quit rates compared to NRT. So my background is in looking at the big population picture. So I wanted to start by thinking about the population impact of e-cigarette use, or really any product use on cigarette cessation, is really a function of the reach of the product and the effectiveness of the product when used. And of course, clinical trials handle the efficacy piece very well. And I think the population-based studies do a good job of addressing the reach question. And by reach, I mean, how many people are using these products and who's using these products? Are there differences in the demographics of those who use products? So for today, I'm just realizing I think we do have not the updated version, but maybe I'll just try to roll with it. I don't know if we're not too late to switch it out, right? Yeah, we'll roll with it. Okay. Yeah, okay, we can roll with it. So today's presentation has two parts. The first one will be looking at the reach of these products among people who are ages 40 and older, smoke cigarettes daily, and have a chronic health condition. So I'll show you data on whether reach differs as a function of data or demographic characteristics and as a function of smoking related characteristics. Then I'll also show you parallel data on the reach of nicotine replacement therapies and prescription medications among the same group of people who smoke daily. And then lastly, I'll show you whether there's any differences in cigarette quit rates between those who were and were not reached at all by each of these product types. So I'll start by talking about the PATH study. I'm not sure if everyone's familiar with it, so I'll make a few comments about this. It's a major data collection effort. Over 45,000 youth and adults in the US are interviewed approximately annually. We include youth as young as 12 years old, which I won't be talking about the youth data today, but we do have those data. The sampling design allows for us to evaluate transitions in product use from wave to wave, but also trajectories in transitions across many waves. PATH also collects biospecimens from adults and youth, so those can be used to measure biomarkers of exposure to harm and exposure to tobacco use and harm from tobacco use. And these data are available to the research community, freely available. So if you ever want to use the PATH data, I'm happy to chat with you. So the study started collecting data in 2013. You can see the different waves that were collected and when biospecimens were collected from people. Right now, wave 8 is in the field. So I'll be talking about data that were used from the two most recent waves that are available for analysis. So that would be the 2021 wave 6 and then the 2022, which rolled into 2023 wave 7. And I will note that we replenish the sample periodically so that we can maintain those nationally representative estimates. All right, so the PATH data in today's presentation, the first part of the presentation, uses those last two waves that are available. I mentioned we focus on adults 40 and up, smoke daily, have a chronic health condition. When we weight these estimates out to the population level, we're reflecting about 10 million people. So just to kind of give you a picture of how many people we're looking at when we think about all adults ages 18 and up who smoke daily in the US, this subgroup of people who are 40 or older with a chronic health condition reflects about a little over a third of all adult daily smokers. All right, so the health conditions that we included here: Path asks lots of questions about all different kinds of health conditions. But for this presentation, we included people who have experienced the 3 heart conditions that you see on your screen there. We included the 3 respiratory conditions here. We also included folks with diabetes and who have been diagnosed with cancer. And of course, there's comorbidities among them. So this is just a distribution of the diseases that were included in that sort of blue piece of the pie there. I want to talk a little bit about population characteristics of this group. Here you can see the age distribution. We had a higher prevalence of females than males. Most are non-Hispanic white. And then this financial stress item in the purple bar there just asks whether people have had difficulty paying important bills on time because of a shortage of money. So kind of getting at an income, sort of the tail end of the income range. BMI, you can see over 30% are in the BMI of 30 or higher range. So again, sort of thinking about the comorbidities among the sample participants. And then looking at smoking related characteristics, you can see that among these folks smoking daily, 45% are smoking a pack a day or more. When we look at plans to quit, and I'll say a little more about plans to quit in the second part of the presentation, you can see that there's the 27% are not planning to ever quit in their lifetimes, which I think is a high and sort of disappointing, disheartening rate. Only 9% are planning to quit within the next month, which is what we kind of think of as near-term plans to quit. And I also added the advice to quit data in here as well. So we have 60% of these people with health conditions have been advised by a clinician to quit in the past 12 months. 28% have not been advised to quit using tobacco, and another 12% haven't been seen by a clinician in the past 12 months. So first, we'll look at the reach, the overall reach of e-cigarettes, and then I'll also show parallel data for NRT and prescription medication. Lots of words on this slide. I just wanted to give a sense for those not familiar with the PATH study. We go through great pains to try to really describe to the participants what we mean when we ask about vaping and e-cigarette use. So we give example brand names. We ask them not to report on their cannabis use in this section of the instrument, of the survey instrument. And then that's the actual image that people are shown, the generic image of vaping products in the 2022-23 survey. So past 12-month use, product use. Here's those data. We have 16% of our sample in 2021 who have a chronic health condition and smoke daily. In the year that followed, 2022-23, 16% used e-cigarettes at all. Compare that to 14% who used NRT and 8% who used prescription medications. And these are not mutually exclusive groups. People can and do report use of more than one product over the course of the past 12 months. So I wanted to just kind of give you a sense of that overlap. So among those who used e-cigarettes at all, you can see that 77% used only e-cigarettes in the past 12 months, whereas 13% also used NRT, another 7% also used prescription medication. So there's certainly some overlap in product use. Among those who used NRT, there was even more overlap. We have only 68% using only NRT. And then among those who use prescription medications, I didn't mention, but that's your varenicline, bupropion, 55% used only prescription, and we see a lot more overlap in use of other products as well among that group. So looking at e-cigarette use and demographic characteristics, we do see significant differences in who is being reached by e-cigarettes. There's an age distribution there. So the younger people have higher rates of e-cigarette use. And by younger people here, I mean 40 to 49. So we're not comparing to the, I appreciate being in being in younger age group here. So often with the 20s and 30s, we see so much experimentation and movement in product use, but we wanted to focus on the 40 and up crowd. We also see a significant difference for financial stress. So people who are experiencing financial strain have a higher rate of using e-cigarettes in the year that follows. How does this compare with NRT and prescription medications? There are no demographic differences in who is being reached in 2022-23 by these two types of products. When we look at smoking related characteristics though, here are e-cigarettes again, and you can see there are no differences in who is being reached by e-cigarette use as a function of whether they're planning to quit, as a function of whether they've been advised to quit. So in other words, e-cigarettes are not attracting people who are planning to quit smoking, more so than those who are not planning to quit smoking. Then when we look at NRT, we see a different pattern of results. Those who are planning to quit in the near term in 2021 have a much higher rate of using NRT in the year that follows. And also those who have been advised by a clinician to quit are having higher rates of NRT use. For prescription medications, varenicline, no significant differences, but we can see we have overall lower rates, and the patterns, I think, kind of line up with what we're seeing for NRT. So just to kind of recap, who was most reached by each product, there's somewhat of a different profile in who is using these products. E-cigarettes are attracting the younger people and folks with financial stress, whereas NRT seems to be hitting on people who are more engaged in at least thinking, planning to quit smoking. So I will show you data on cigarette cessation rates at follow-up as a function of any product use in between. And I mention any use because this is sort of the broadest amount of use. So we wouldn't expect that one use would be effective, but I wanted to kind of give the big picture here first. So these are the cessation rates in 2022-23. And as you can see, two of them popped out as being statistically significant with all adjustments, but really the blue bars there, no e-cig use compared to e-cig use, 5 versus 9% quit rates are the same as what we see for prescription medication, 5 and 9%. Didn't hit significance, but lower sample sizes for prescription medication. And then NRT comes out as being 12% overall quit rate among those who used it at all. And I can't dig into all of the details, but I do think it's important that we think about from a population perspective, whether people are using it as directed or as necessary to be effective. And you can see that for NRT here, we had 12% overall quit rates, and we have 11% of the people who used it actually used it for 8 weeks or more. So it shouldn't be surprising, I think, when we see how the sort of low adherence to use as a possible reason for why we're seeing low overall quit rates in the population. So just a quick summary here, 10 million adults, they're smoking heavily. A good fraction of them don't plan to ever quit. 60% were advised to quit. In 2022-23, we do see that this group of people trying e-cigarettes, in different groups are trying. Younger people, those with financial stress. NRT is reaching those who are more engaged in thinking or planning to quit smoking. Okay, and those are our overall quit rates. And of course, this is looking at overall quit rates, look at the aggregate of all mechanisms. And when we think about product effectiveness, which is not what I'm focused on today, but I do want to point out that oftentimes the effectiveness component looks at people who are attempting to quit. So this is kind of the visual I think of when I read clinical trial studies and even the population studies that have tried to get at this question. But I think another important question is, what about people who are not planning to quit? We see there are lots of them. Is there any potential for e-cigarettes to have some sort of role in moving people from not planning to actually quitting smoking. So this is a paper we published where we looked at this question in the past study data. And basically we found that people who were never planning to quit smoking and were not using e-cigarettes at sort of baseline wave experienced a much higher odds of cigarette quitting at follow-up when they took up daily e-cigarette use. So those with no plans to quit, perhaps, we would never want to count them out, but even in terms of medication or potential cessation opportunities. We also looked at this question using the ITC data, which is an international study very similar to path and design. And we found essentially the same findings here. I didn't add them all in, but okay. So the question I ask is, have the times changed? We did publish a paper recently where we looked at trends in cigarette quit rates across 2021 or 2013 to like 2021. And we do see population trends overall increasing gradually, quit rates among all people. But when we look specifically at people who use e-cigarettes, we see that trend rising steeply and really kind of bending at the point where the salt-based technology came into play. So after like 2017. So I do think there's some change. My background is in tobacco regulatory science. So when the CTP director comes out with a commentary saying for adults who smoke and have tried FDA-approved pharmacotherapies with no success, medical providers may consider education about the relative risks of tobacco products. So for us in our field, this was a big deal, and I think an indication of kind of a shift in where we're at in tobacco regulatory science. This is just a snapshot of the web page, because FDA now has a web page where people can go and find information about relative risks of tobacco products, which is something we really didn't talk about in the past. So these are just snippets from the web page where FDA says no product is safe, but generally non-combusted products generally have lower health risks than other combustible products. Just a few more snippets here. To adults who continue to use these or who choose to use these things, it's important to ultimately try to switch completely from smoking to vaping. And so, yes, in my world, FDA always gets the last word, but not today. Here, the last word goes to Dr. Agati, who published this lovely commentary in the New England Journal, stating in part, it is now time for the medical community to acknowledge the progress with e-cigarettes and add e-cigarettes to the smoking cessation toolkit. So that is where I will leave it. Thank you.
Yeah, I think there's a switch. Yeah, great. Thank you. So these two papers, wonderful papers, are open for discussion.
I was intrigued by, Janet, what you said, that for that a novel product needs to compete in rewarding value and reinforcing value, not just in the craving relief and withdrawal relief. And that made me think about the fact that in the e-cigarette world, at least what we've seen is that adults seem to prefer flavors that compared to not flavors. And I wonder if people have looked at the rewarding value of flavors and not flavors versus tobacco flavors, and whether that would make an argument for flavors, because as you know, this is a very hot topic in policy as to whether we should restrict flavors to tobacco flavors.
So we have 15 participants enrolled so far in a study that's testing just that. So do flavors impact the substitutability of e-cigarettes for combustible cigarettes?
Nancy, do I ever have a paper for you if you haven't seen it? So we just had a JAMA Network Open paper come out looking at just that issue with regard to VONC cigarettes and what level of reduction you see with them, depending on whether you give them an e-cigarette with only tobacco flavor, or an e-cigarette where they could get access to fruity or other flavors. And the data are quite clear and robust that the flavored e-cigarettes enhance the VONC effect in terms of reductions in smoking rate. So, yeah. And very much attributable, it just came out. So very much attributable, I think, to the reinforcement process. Yeah.
Great presentations. My question's for Karen. I was curious if, I know it wasn't presented, but if you've looked at the data and cessation approaches with the American Indian population that I know is small but available in PATH. And then the other new kind of exciting question that is available in PATH is rural. And so I was just curious if you are or have plans to look at that.
Great questions. So wonderful questions. No, I have not looked at the American Indian population. I would certainly love to. We actually have a wonderful program where we partner with Indigenous peoples and at Roswell and bring in students who do projects. So I'm hopeful that I'll be able to, in the near future, work with a promising young student to really kind of engage in even just sort of general data that can speak to that. And the second question, I didn't write it down. Oh, virality. Yes. Great one. I believe that question has recently, or the data that are available on that have recently been sort of enhanced. So I've not looked at it, but that's on the to-do list as well, and very important questions. Thank you.
Hi, thanks. That was a really great presentation. My questions for you, Karen, maybe a little bit for Nancy too. My name is Sarah Pratt. I am at Dartmouth and I do e-cigarette research. I've been doing research on e-cigarettes as harm reduction for people with serious mental illness since around 2013. And I, in May, had an R01 funded to test a behavioral support intervention that will be added to e-cigarette provision versus provision only randomized controlled trial. And in going around to my sites and just continuing to try and dispel the very pervasive myth that e-cigarettes are much worse or at least as bad as cigarettes, I have these slides that show like position statements from the American Cancer Society and from the American Society of, I think, Public Health Physicians and so on. And they're all saying basically, e-cigarettes are less harmful compared to cigarettes. But when I look today, and these are statements that came out in 2013 and 2018, when you look today, those are gone. You can't find those statements anymore. They've removed them. The American Lung Association has this very strong, e-cigarettes are bad, don't use them. They're trying to trick you into thinking that they're less harmful, blah, blah, blah. And so I'm worried that I mean, you mentioned a tipping point, but I'm worried that there's a pendulum swinging back. I don't know if anybody can comment on that or it concerns me because it's hard for me to wrap my brain around the idea that a combustible cigarette is that an e-cigarette, which has no combustion, is just as bad or worse than I can't wrap my brain around that. And yet I feel like we're swinging backwards. So.
Sure. Yes. And this harkens back to, I don't know who it was yesterday who was talking about EVALI and just sort of the persistence of misperception. I guess I would say, again, my sort of perspective is really this tobacco regulatory science perspective, but I do believe that there is a concerted effort on the part of the FDA to try to change the narrative on e-cigarettes. There's the webpage, but I believe they've also recently awarded a large grant to an organization, I can't remember who, to specifically do research into developing communications and how to communicate differently to different groups to try to reach people. So I do think, you know, there's hope that we're moving in the right direction there, but I think with all things, it takes time to reach everyone, to trickle down.
And now all the statements are gone.
Oh,
Yeah, I was not aware of that.
Yeah, I don't know. Subscribers and staff and, you know, they seem to be convinced by what I was saying.
Yeah.
But then it's like, oh no, you can't find the statements on it.
Well, so I think we're starting to make changes in that. Clear that most Americans, if you ask them questions about the safety of e-cigarettes, they think they're just as bad as cigarettes. And that's certainly true. And I think probably an awful lot of physicians and other clinicians would say the same thing. But I think that my view is that we now have evidence that they do help people to quit smoking. And I think that's pretty strong. And actually adding your population perspective to it is helpful as well from a kind of triangulation way of thinking about it. And I think that we're trying to make I was hoping I could like nudge people a little bit. That was a nudge. And it was a very carefully said nudge because you have to talk carefully to this audience. But I can tell you of a few things. One is that I know that at least one of the cancer organizations who have not been favoring e-cigarettes I'm told, I'm not on the guideline committee, that they're discussing whether or not they should take a different perspective and not be completely anti e-cigarettes. And they've been very worried about the cancer effects of e-cigarettes so long term. The second is the Canadian Cardiovascular Society just this summer have just as of like yesterday finished a guideline for how cardiologists in Canada should take care of people. And they changed their views about e-cigarettes, helped along by Neil Benowitz and myself and a couple other people up there who have the same perspective. So I'm seeing like little bits of change that are happening. I even think that some of the big American cancer societies might be changing. So I think it's a gradual process.
yeah, what?
No, they haven't changed. No. Yeah, yeah, I know. I think I feel like I play defense a lot. But I think that what's happening is that there's evidence that they do help people. The concern is now the harm. But the concern I think is more the harm with long-term use. I think that the data from the clinical trials would make an argument that for at least a year or two, it's not more harmful. They're not seeing AEs in those trials. So it seems like it's probably not more harmful for short-term use. And that what we really need to think about is it's a two-step process, that you first move people off of combustibles, and then the next step is move them off of the nicotine if that seems important. I mean, there's some people that think we should be a nicotine-free society, others that have a broader perspective. And that's an argument that we're going to have for a while.
Yeah, I would just add that nuance is a problem when you're talking about broad numbers of people, in my experience. And I've had recent experience with the data that I shared with Nancy or mentioned to Nancy a minute ago, in that I was invited to give a presentation to our cancer center's research retreat. And so most of the people in the audience were cancer docs who don't do tobacco control. And so I presented the data, and there's a brief Q&A session. The only questions I got were about the harms of e-cigarettes, not any of the implications for harm reduction or substitution, just about what about the kids? What about the cancer risk? What about, and so I just gave up, put up my hands and kind of left. But where I want to come back on a more optimistic note is at the beginning of this conference, I mentioned the importance of advocacy. And I think what Nancy was just doing there, mentioning the progress, it's going to be incremental, is that we all have to be advocates for the more nuanced position. You know, that we don't think they're perfectly safe, but we know scientifically they're safer. That's that my Q&A ended with emphasizing the word safer relative to cigarettes. And yeah. Yeah, so we aren't some of the questions, Grace? Yeah.
So I have a question that's unrelated to the topic.
Yeah.
So I don't know if other ones.
No, please go. Go ahead.
So my question was to Janet about your research, and you found no sex differences, and you did a really rigorous study that has high internal validity, which is really important. But I was sort of thinking about, you know, what else comes with tobacco products and nicotine products that adds to these sex differences, for example, marketing, right? So we talked about how, you know, IQOS is, you know, how they sell it, even the stores are different. And so I'm wondering how some of those aspects might contribute to sex differences that might occur. So it's not really related to your study, but more thinking about sex differences in broad and how IQOS could be contributing to that.
Yeah, I mean, I think the marketing for IQOS, there's been a respite in its availability in the US, but now that the adjudication of the patent issues is, you know, completed. But the stores and how they go about, you know, selling IQOS, I mean, it's very high tech, very slick, sophisticated. So I think they're, whom that, I don't know who that will appeal to, but that's going to be an interesting, thing to look at, keep track of when they return to those stores. Yeah.
Yeah, I think it's a great question, Grace, in that when I was listening to Janet's report, we did a study, a double blind, very similar to the design that you used, Janet, looking at research cigarettes that varied in nicotine content and the relative reinforcing effects of them at different doses. And we then went back and looked at sex differences. We saw no sex differences. So, I have the highest regard for Ken Perkins and all the data, but when you get in the lab and rigorously manipulate, in our study, nicotine was controlling behavior in women and men, strongly, and we saw no differences in that. So maybe there are other things going on that influence these differences in response to NRT or whatever, but in the lab, it's hard. We had a hard time seeing them.
Yeah, I think there's a lot of other factors in the real world that contributes to the appeal and reinforcing effects. Actually, it's not just nicotine, in addition to like flavors that you mentioned, and as well as marketing that's often overlooked.
Yeah, good point.
Howdy, my name's Rolf Parker from PHRR, and I'm a Vermont Department of Health grantee. And prior to working at this job, prior to working in the Prevention Coalition, I worked for 8 years at a reference desk in a library. So that's part of how I got my job. And I just wanted to say that I'm a little nervous because I'm a minority opinion within the confines of these four walls, or I suspect that. But I think there's a lot of good reasons why these statements are disappearing from the ALA page and others. As the review articles keep coming across my desk, the mounting evidence of harms, there's not actually a consensus that they're safer. That's not remotely true currently. There are so many warning signs. I'd say one of the more recent papers, for example, out of Ohio, which found actually not a 300% increase, a 400% increase in lung cancer diagnosis in dual smokers, dual users, for example. And the mouse studies as well are not really breaking the right way. So I'll stop there, but I feel at least the need to express that there was not a consensus on the word safer at this point. And this is why it's not incidental that these things are disappearing from the ALA page and other pages because of this lack of consensus. So I'll just stop there, but thank you.
I would just add a point about the preponderance of evidence. You can point to individual studies and maybe they're more recent, but I would take the position that the preponderance of evidence is still strongly in the direction of safer, but not safe.
Part of what we have to do though is also consider percentage article came out this year where they found if you had any associations with the industry, you have an 8% chance of declaring harms. If you have no associations, 92% chance of finding harms. So all of those papers have to be removed from, I would say, from an analysis of this preponderance. That's just one problem with the preponderance. We should have a conversation later about it. But I would just say at baseline, there is not consensus. Of course, in science, there's never 100% consensus. I'm not talking about that. The fact that the LA removed it is not a small, it's not just a small thing. And the other pages, and that's because of the information I feel that's pouring, pouring across the desk.
Yeah.
Autism, cancer, lung cancer, heart disease. I mean, you can't, I think it's true that you can't look at individual studies. But dual use is a more complicated issue.
Nuance.
People are just using e-cigarettes and not using cigarettes. It's very hard to say, well, like dual use people getting lung cancer. Okay, they're smoking cigarettes. It's not cigarettes. What's that? Yeah.
Okay, I'm going to take the prerogative of moving this forward. So we have a question here, please. Yeah.
Hi, thank you so much. Garrett from Brown University, Center for Alcohol and Addiction Studies. I'm curious about Janet. So I worked on one of the original Shrek studies, and per that, we actually had to take the e-cigarette back. And I'm just curious about the sustainability of these switching interventions and if your participants get to keep the IQOS at the end, or if you provide any documentation on how to help them purchase new ones like in the future and what that looks like.
Yeah, so they got to keep the IQOS device and any of the heat sticks that they had left. And for at least part of the time of the study, they could then go to different sites and order heat sticks. And as I've learned, heat sticks are available through a number of different third-party vendors. Yeah.
There are questions? Yeah, please.
Yeah, hi, I'm Jared Thatcher. I work at the Tobacco Control Department, the State Health Department. I was just wondering about IQOS. Are you concerned, and this also goes for using e-cigs, I guess, to quit smoking. Are you concerned that there's not really a behavioral component to the quitting? I was just thinking like, a big part of quitting an addiction is like getting rid of those behavioral cues. And I'm wondering if you think the behavioral cue of IQOS or e-cigarettes might cue people to pick up smoking again, as some of the data has shown.
I'm not aware of any data that shows that after IQOS use, they pick smoking back up again. But these were participants not interested in quitting smoking. So to provide counseling for them to quit smoking would be a disconnect. But I do believe that if there, was a study where individuals interested in quitting smoking were being enrolled, then I think that there needs to be a behavioral component to that as well. Yes.
Other questions, comments? All right, we'll go to break and we will be back at 10:50. So applause for the presenters. Thanks for those presentations, really, they're both terrific.